Good evening, everyone. Thank you for joining us. We will start shortly. We're waiting for more people to join and we'll start shortly.
Very good afternoon to everyone, and thank you for logging in. We'll start because it's already 4 o'clock. And Pranjal, if you could just keep a watch on the way, the wait room, and whoever is planning, wishing to join, they can also join in between. So first of all, as I said, we had a brief introduction to these PHO trainee sessions on Monday, where ECHO team briefed us about the features of Zoom and how ECHO has been helping us to provide this platform. Now, today is going to be the first real teaching session on this platform, and you all will agree with us that this is still kind of in the trial phase, and we will be really glad to have inputs from all of you. And I hope I'm visible. I'm audible. Can you give a thumbs up? Yeah. Okay. So your feedback is going to be very, very valuable, and as we go along, we'll modify and tweak it to be able to cater to the requirements of the students especially. So before we start today, I'll just take a couple of minutes to introduce today's topic and also the esteemed faculty which we have today as experts. We've just chosen retinoblastoma today as the topics to be discussed, and it's a relatively common pediatric problem, and also I also understand that probably least kind of importance being given, especially in bigger centers. And so we thought it's a good topic to begin with, and we can doubts during this presentation. I have got three very senior faculty who are going to be the experts for the session, and we'll pose questions to them, and also your doubts, whatever you have, can be clarified. I have got Dr. Amita Mahajan. She's a senior hematologist pediatric hematologist oncologist at Apollo Hospitals in Delhi, and has extensively worked in retinoblastoma for last so many years, and is also one of the leads in the next INPOG retinoblastoma study. I also have Dr. Deepak Bansal as expert today, and we all know he's a professor of hematology oncology at the Pediatric Hematology Oncology Department at PGI at Chandigarh. He was the ex-secretary of the PHO chapter and a very senior colleague in the Pediatric Hematology Oncology field in India. I also have a guest faculty today. That is Dr. Feroz. Dr. Feroz is a ophthalmic is an oculoplastic surgeon. She's ophthalmologist, special interest, and trained in ocular oncology, and her special interest is retinoblastoma. So it's going to be great to have a perspective from an ophthalmologist on various aspects of retinoblastoma care. So with that introduction, so we will start the session. So I'll just do a little brief on retinoblastoma chemotherapy for the next 15 to 20 minutes. Post that, we'll have some case presentation, which is going to be done by Mohan Reddy, who is FNP fellow working here at Narayana Health, Bangalore. And during that presentations, we will use our experts and the faculty to answer to some of the questions. And as I said, you please keep on, posting your questions, and we'll take them at the end of the session, and we'll ask the faculty those questions. And you're most welcome to either write or speak up and interact with the faculty directly at the end of the session. So with that, I will start the first component. That is the chemotherapy component of retinoblastoma. All right, so I hope the screen is visible to everyone. Yeah. Now, before, so we know that retinoblastoma is, the most common pediatric intraocular malignancy, and it is probably the third common intraocular malignancy for all ages. And there's estimation that around 8,000 children worldwide are born with retinoblastoma every year. And we also know that it can be either unifocal or multifocal. It can also be unilateral or bilateral, unilateral being the majority. That is, about 70% being unilateral and 30% being bilateral. unilateral. It can be sporadic, but there is some percentage of patients can be familial, which comes from their families. And there can be hereditary component about 40 to 50% of these retinoblastoma patients. Now, when we, it's a very a nice slide. I'm not going to, spend a lot of time on this, but I think retinoblastoma gene discovery and its, as we have understood retinoblastoma gene more and more in the last 2 decades, has not only helped us in understanding retinoblastoma, but also has helped us in understanding the pathophysiology of many other oncological conditions. And I think I request, I suggest that you should go through this interesting paper wherein, you go through the journey of the retinoblastoma gene has been identified, and also how we understood the mechanism of oncology, of pathophysiology in retinoblastoma. Now, when you go to the natural history of this disease, it's a rapidly progressive tumor, we know, but most of the times it initially starts intraocularly and remains intraocular for a relatively good amount of time before metastasizing. So all the metastasis is a rare presentation in developed countries, but it's not that in developing countries like ours. Sometimes there can be a that's usually a consequence of a retinal artery occlusion or a severe inflammation and massive necrosis. Now, what are the routes of spread? The most, the common is direct local tumor infiltration through the choroid, and that it can, through those choroid invasion, go into sclera and orbital soft tissue. The next common is subarachnoid space of the optic nerve. That means through the optic nerve, it can go into the CSF, then into the brain and spine. There's anterior spread also possible, which can go to through that. It can go to the anterior to conjunctival eyelids and extraocular tissues, and sometimes hematogenous spread also can occur, especially to the bone marrow and other lymphatics. Now, what are the what are the diagnosis and the extent of disease evaluations in retinoblastoma? How do we do that? Now, we all know that this is one of the diseases, oncology problems, where we do not biopsy for confirmation. So it's mostly a clinical and imaging diagnosis. And examination anesthesia is one of the most important, initial evaluation, and that should be detailed examination by a trained pediatric ophthalmologist with experience in retinoblastomas, wherein they document not only the number, location, but also size of tumors and other associated things like retinal detachment, how much retinal subretinal fluid is there, presence, absence of vitreal seeds, and that has to be mentioned and documented. Sometimes it will be a little difficult and challenging to have a look under EUA. If, for example, if there's a massive retinal hemorrhage or retinal detachment, your assessment on EUA can be sometimes challenging as well. Now, additional imaging is required, and ultrasounds and CTs have been used in the past, but the MRIB is the most common and most widely used imaging modality at this point of time to understand the local as well as the CNS spread of retinoblastoma. And additional procedures, staging procedures will be required, like bone marrow and lumbar puncture, which we'll be discussing a little bit later on. Now, how do we stage it? The initial staging which was evolved, what is the traditional RE grouping system, and that was basically the era of external beam radiotherapy, and that is something which that is something which was evaluated to understand the outcome of external beam radiotherapy, and there were 5 groups based on that. But that's kind of no longer being used in the contemporary times. So what we use now is something called as International Classification Intraocular Retinoblastoma, or ICRB classification, wherein we classify retinoblastoma in 2 ways. One is classification of intraocular tumors. That means retinoblastoma which is restricted to the eye itself. And then we have got group A, B, C, D, and E. Group A being the least, and the group E being the most advanced intraocular malignancy. I will not go into the details of these, but these are the 5 groups of intraocular retinoblastoma. These are the images which basically show you the different types of different grouping of intraocular retinoblastomas, and we'll again discuss this later on with Feroz Bindas. She'll be able to explain these images to us better. Now, going on to the external extraocular staging or extraocular retinoblastoma, and how we stage that. And there is a staging system, is international staging for extraocular retinoblastomas. We start from Pranjal. May I request you to remove me as be one of the co-hosts, because I'm getting a lot of these pop-ups for admission and all that. Can you do that for at least till I'm taking my session?
Yeah, I've done it.
Yeah. So international staging system for extraocular retinoblastoma, which there is a stage 0, which is patients who are treated conservatively, and we again that's basically most related to intraocular tumors which are conservatively treated. But then stage 1 would be that eye is enucleated and there is no microscopic residual disease left. Stage 2 will be enucleation, residual disease. Either it's an orbital disease that must come out of the ocular and gone to the orbital cavity, or a lymph node static. Either it has gone either without CNS, maybe into bone marrow or any other, into to the chiasm or a CNS mass, or even CSF or meningeal involvement. Now, the prognostic factors of retinoblastoma is predominantly those which determine its spread out of the ocular, out of the eye, and the most important being, as I said, optic nerve invasion, also invasion of the choroid. If it's a poorly differentiated tumor, if it has gone to the anterior chamber, if there are large vitreous seeds, it is glaucoma. If there are bilateral tumors, trilateral retinoblastoma, and extraorbital extension, whether it's in the orbit or it's in the neck, metastasis in the lymph nodes or elsewhere. So these are the ones which have got bad prognosis, and we'll deal with them later on in the presentation. So now getting on the treatment, which is the predominantly I'm going to be discussing the chemotherapy component of the treatment. So we all know that retinoblastoma is a classical example of a multidisciplinary team, wherein a team of pediatric oncologists, ophthalmologists, and radiation oncologists, and also to an extent a genetic disease specialist or genetic counselor plays a role in managing these patients. And the aims or the goal of therapy is, the first goal is to eradicate the disease to save patient's life. So patient's life is utmost important. And second would be to save vision as much as possible. And third, of course, is to decrease the late sequelae from the treatment, especially the second neoplasms. Now, what are the different modalities of treatment which are employed? Enucleation being one of the traditional and the most older form of treatment for retinoblastoma, but then we also have local treatments which are used by the ophthalmologist. We have systemic chemotherapy, we have intraarterial chemotherapy, and intravitreal or subtenon or subconjunctival chemotherapy, and also radiation therapy, which can be either axial beam radiation or brachytherapy for the management. So from the treatment point of view, we basically, again divide these retinoblastoma into 3 major categories. One is unilateral, that means retinoblastoma one eye, and how do we deal with it? If there's a large intraocular tumor, then we of course will go for enucleation, and with or without chemotherapy after enucleation. But if it's a if it's not a large intraocular tumor, it can be an eye and the vision can be saved. You probably go with chemo reduction followed by local treatments with the ophthalmology colleague. Bilateral retinoblastomas, the principle of treatment remain the same as for unilateral retinoblastoma. The only difference being that in bilateral retinoblastoma, because it's bilateral, there's an added stress on, and there's a intent to have conservative approach to save the eye and the vision as much as possible. When you go to extraocular retinoblastomas, we'll go through these in detail later, but then the principles of treatment are basically chemo reduction followed by radiation therapy, and in some cases we'll also give them high dose of chemotherapy, especially the ones which are stage 4 ones. Here the high dose of chemotherapy with autologous rescue can be employed as one of the treatment modality. Now, chemotherapy retinoblastoma, a little bit of the history. This was first time tried in retinoblastoma in 1953 when first time nitrogen mustard was used for the treatment. But then the concept of neoadjuvant chemotherapy or chemoreduction was basically introduced first in 1976, wherein they used to deliver systemic chemotherapy as a primary neoadjuvant therapy to reduce the size of the tumor, so that the local therapies, which were at that time predominantly axial beam radiation and enucleation, would be employed. And they found that these chemoreduction modalities would work and reduce the size of the tumors. Now, the second way which we introduce chemotherapy in retinoblastoma is in the adjuvant setting. That means you have already enucleated the eye, and then you are giving chemotherapy post that. Now, all the patients who get enucleated would not receive chemotherapy unless and until they have high-risk features. And what are those high-risk features? The high-risk features are that if the tumor has invaded, posterior to the lamina cribrosa, those who have got a 3 mm or higher choroid invasion, those who have got choroid invasion and prelaminar optic nerve invasion, both of them are present together. Or there's a tumor invasion to anterior chamber. So all these settings, the high-risk features means there's a high risk of the retinoblastoma getting metastasized through hematogenesis or through lymphatic system, and that's why we want to give them post-enucleation adjuvant chemotherapy to control that spread from the ocular, from the eye. Now, the various drugs which have been used are just listed here, but we know that VC is the backbone of vincristine, etoposide carpenter, the backbone chemotherapy for retinoblastoma. And this was employed first time in 1996 by Shields et al. And we know that the amount of work which has been done in retinoblastoma by this group is quite immense. They employed it first time in 1996, but it was given in a chemo reduction setting, and they tried to treat about 20 odd patients with VEC. And what they found is that there was complete response in about 56% patients, and about a partial response in about rest 54%. All the patients responded to various extents. The same group, they used this combined chemoradiation and adjuvant treatment, that's intraocular therapy. So they used 6 cycles of VC and also used local therapies in the next group of patients, in about 32 patients, and then again saw applying VC chemotherapy 6 cycles and other local therapies like cryotherapy, thermotherapy, and plaque therapy, and sometimes the patient had extensive disease, external beam radiation. What they found is that there was a good ocular salvage, and they could avoid external beam radiation in about 25% of the patients, and almost 70-80% of the patients could be even with stage 5 RE stage could be saved. But this was the landmark, I think, a landmark study which was published in 2000 in the Journal of Clinical Oncology, where they analyzed the effects of VC chemotherapy and in the different groups, in the different intraocular groups. What they did, that they gave this VC chemotherapy and found that the patients who had group 1, 2, and 3 eyes, they had excellent results. And in these patients, they could avoid both enucleation as well as axial beam radiation. So that's the 2 modalities of treatment which have got long-term morbidity as well as risk of losing the eye. In these 2 modalities could be avoided in 1, 2, and 3 group patients. Of course, in 4 and 5 group patients who were a little more advanced, this could be achieved in about half of them. So it's a good encouraging results, and this is just a graph to demonstrate that. This is the overall, the whole group, cohort of patients, and this is on the right hand side. If you see the group 1 and 2, group 1, 2, and 3 had almost 100% long-term survival and long-term vision was also, eye was saved. But in group 4 and group 5, the results of course were inferior to group 1, 2, and 3. So these similar results were also kind of replicated by other groups. There was also an attempt to see other chemotherapy regimens like etoposide and carboplatin or vincristine and carboplatin, but they were found to be inferior to VEC. So that's how VEC has still remained the gold standard of chemotherapy backbone in retinoblastoma. Now this VEC, these are the dosages here, and we can administer it in a standard dosage, or sometimes we can give the higher dosage as well. So that's called as high dose VC and the standard dose VC, which has been shown in this. Now the second group, as I said earlier, is extraocular retinoblastoma. These are more challenging because there's a very interesting phenomenon of the retinoblastoma. As long as the retinoblastoma of the eye, it can be controlled. There is good long-term survival in those patients. But as soon as the retinoblastoma becomes extraocular, whether it is orbital or a lymph node spread or a metastatic spread to other parts of the body, the outcomes and the prognosis gets very, very poor. So these we know have got poor prognosis, especially in our country, where a lot of patients present extraocular disease. This we have already seen the staging system. Now, what are the options of treatment in the extraocular retinoblastoma? If there's a regional extraocular disease, that is stage 2 or stage 3, either it's orbital or there's a lymph node metastasis to the lymph nodes. So these patients are treated with conventional systemic chemotherapy and then followed by external beam radiation. Now, what chemotherapy to be given to these patients? So there's various protocols which have been used. Where are the chemotherapy regimens which have been used? One of the regimens which was used in Argentina, they used a couple of protocols. One was based on vincristine, doxorubicin, cyclophosphamide. The other was based on vincristine, idarubicin, cyclophosphamide. And what they showed is, and then this was followed by 4,500 centigrade of radiation up to the optic chiasm, to the orbital disease, and also to the nodes if there was lymphadenopathy. They could see 5-year event-free survival of about 84%. So this was proof of principle that if we treat them aggressively with chemotherapy followed by external beam radiation, we can still achieve good, decent, or long-term cures. So similar findings were also shown by other groups, both in North America as well as Argentina, although with different chemotherapy cycles. The ones which were used by these groups were ifosfamide and etoposide based, alternating with cisplatin and timiposide, and they also used 4,000 to 5,000 centigrades of external beam radiation, and they could also achieve long-term cure rates to the rate of 60 to 70%. Now, going on to stage 4, A and B, these are the ones where there's a metastasis either to the bone marrow or to the CNS. And these are the ones which have not been traditionally been doing well. These are patients who have got very, very poor outcome. And one of the things which has been used in these patients from the chemotherapy point of view has been high-dose chemotherapy with autologous stem cell rescue. Now, autologous stem cell rescue, one of the earlier publications was from Korea, where they used autologous stem cell rescue in 14 patients of bilateral advanced retinoblastomas. So these are bilateral advanced retinoblastomas, not necessarily metastatic. What they showed is that out of these 14 patients, 9 patients received tandem autologous transplants, and followed by one had external beam radiation also after that. And then these patients, they could at least save in 9 out of 14, they could say at least one eye they could save as a result of this high dose chemotherapy. So similarly, high-dose chemotherapy has also been used in metastatic. This is data from South America, where they used metastatic retinoblastomas, whether it was a bone marrow metastasis or orbital extensive orbital disease or the CNS metastasis. What they used is this high-dose chemotherapy with autologous stem cell rescue. 7 patients out of these 11 patients had disease-free survival. So again, showing that you can probably salvage 60 to 70% of these patients using autologous stem cell rescue. Now, what about the stage 4B? This is the one group which has got the worst prognosis, the one where the metastasis has happened either to the brain or to the meninges. So we know these patients do quite poorly with whatever treatment you give them. So there's again some data on use of autologous stem cell therapy after high-dose chemotherapy. There were some about, I think, 7 odd patients, but out of the 7 odd patients, there were 2 patients who had survival, event-free survival of 40 and 100 months. This is too short a follow-up, I feel. So we have to probably see whether these two patients also continue, to maintain remission or not, which is not known. But just showing a little bit of hope there in these high-risk patients, where you can give them induction chemotherapy followed by high-dose chemotherapy. Now, what about trilateral? What about trilateral retinoblastoma? This again is a very difficult group and universally dismal prognosis. And this is a paper wherein they tried to give again a combination of intensive chemotherapy followed by autologous transplant, and they showed in 5 patients had event-free survival of about 3,204 months out of the 9 patients they had treated. And this is basically the treatment they used. They used cyclophosphamide, etoposide, and cisplatin-based regimen, which was quite intense in the induction also, and then high-dose chemotherapy followed by the induction chemotherapy to consolidate with autologous stem cells. This is that group, the patients who had no metastasis in trilateral retinoblastomas did little better. That means around 60% could have a long-term survival. But the ones with trilateral retinoblastomas who had metastatic disease elsewhere, the outcomes are very, very poor. Now, this is the latest kind of the study which COG undertook, and they tried to see the effect of induction chemotherapy, which was based on vincristine, cisplatin, and cyclophosphamide and etoposide, as an induction chemotherapy for patients with stage 2 and stage 3 retinoblastoma, that is extraocular retinoblastoma. But the patients who had stage 4, either A or B, after this induction chemotherapy, they offered autologous stem cell infusion as an additional treatment. And the radiotherapy was given in patients of stage 2, stage 3, where the orbital or regional lymph node was irradiated, and also some of the other patients of stage 4 and stage 3, where the radiation was to give the initial sites which were involved based on the response. So this is this has been published, partly the results. This was published this was presented at ASCO a couple of years back, and what I could gather from that is that in the stage 2, stage 3, with this treatment strategy, they could have a long-term cure, about 75%. But the stage 4 and A and B, even after this treatment strategy, the outcomes are very, very poor, to the tune of 8 to 10%. So that was on the treatment of extraocular retinoblastomas. Now, what are the new treatment modalities? Intravitreal chemotherapy can be given. We'll have that a little bit more later on when we discuss the case. Intraarterial chemotherapy can be given directly injected the ophthalmic artery by the neurointervention specialist. Periocular chemotherapy injections can also give, which can increase the intraocular levels of the chemotherapy drugs. So this was basically just a brief of chemotherapy agents and how chemotherapy can be employed in different settings of retinoblastoma. With that, I would now go to the next stage, and that is to discuss the cases. So I've got here Dr. Mohan Reddy with me, who is going to. Prajal, can you give me the screen sharing, please?
So you already have access to it.
Okay. So no, this is saying that host is disabled.
Yes, sir, I've given you the access.
Yeah. So Mohan is going to present some cases, and we will during the case presentations itself, we will discuss some of the aspects of these cases. And here's where our faculty today and the experts today will be helping us with some of the issues which will be raising during this process. So I hope Dr. Deepak, Dr. Feroz, and Dr. Amita are there and are listening to these case presentations. Dr. Feroz, are you there? Yes, yeah. So I think you may have to unmute. Pranjal, are the others experts unmuted?
Yeah, I've unmuted, so I'm just giving access to everyone to unmute
Yes,
themselves so
yes,
they can
yes,
do it
yes,
according to themselves.
yes. And Dr. Amita ma'am, are you there? Yes, she's there. And also Dr. Deepak. I'm sorry, I'm calling out names because I can't see all of you on the screen. Thank you very much. We'll go to the first case, which is going to be taken by Dr. Mohan.
Yeah, good evening, everybody. This is case 1. He's a 5-year-old male presented at the age of 2 years in February 2017 with a history of white previously. So slide is different. Sorry. Yeah, which presented in February 2017 with history of white eye reflex in right eye, and he was evaluated for the same. And MRI orbit was suggestive of endophytic retinoblastoma in the right globe with calcification and thin subretinal fluid. And there were tiny bands of less than 2 millimeter along the midline caudal aspect of the vitreous in proximity to the mass, suggestive of vitreous seeding. And the bone marrow and the CSF evaluation was done, and it was normal with no evidence of any malignant cells. And this was these UVA pictures, and which were suggestive of temporal tumor with diffuse vitreous seeds. If I now
if we can, take a question here, Dr. Feroz, if you could help us with this EUA, because when you get these images, this all looks to us, just a cloud there in the eye, and we have no clue what we're talking about. So if you could just help us with this image and explain how how we as oncologists can interpret these images, and how do we stage this particular patient. Dr. Feroz?
Well, ma'am, I've unmuted you.
I was muted, Sunil.
Oh, sorry.
The host had muted me, yeah.
Can you unmute everyone, Pranjal?
Yeah, sir, I've unmuted everyone. I've given access everyone to unmute themselves. I don't know why this is happening.
Okay, sure. No problems. No problems. Okay.
Name. Okay. Mr. Thomas, I'll just
Request everyone to kindly mute themselves,
he's
please.
heading over the entire submission of the community, and I think he will be the best person. Hello, can you hear me now?
Yes, we can hear you now, Feroz.
Okay, there was lots of disturbance in between. Is it clear?
Yeah, now it's clear.
All right, yeah, fine. Yeah, so this patient was a unilateral retinoblastoma, and what you see here is a RETCAM image of the fundus of the right eye. Now, what is really seen glaringly here, he has a temporal tumor, where the fovea seems to be obscured by this large tumor, and there is surrounding vitreous seeds. So what you see inferior to the main tumor is a cloud of vitreous seeds. So when we talk about vitreous seeds, there are two ways that we classify it. One is whether it's focal or diffuse. Focal is any seed. It can be tiny seeds which is within 3 millimeters around the tumor, and anything which is away from the tumor, more than 3 millimeters away from the tumor, it becomes diffuse. Now, morphological classification, we have clouds, we have dusting, and we have spherules. So this is kind of a mix of everything. You can actually see the dusting of the vitreous around, like a halo around, and this bulk of cloud which is sitting beneath. So that's not a tumor. It's actually a vitreous cloud which is sitting in there. So whenever we see a patient, and try to prognosticate about, of course, the outcome of the treatment and also the visual prognosis and life salvage, here, of course, the life salvage is good because, you don't have any clinical high-risk features suggesting of a systemic metastasis or a micrometastasis. Visual prognosis, yes, because as you can see here, the nerve is absolutely healthy. And although the fovea is obscured there, it is a vitreous cloud which is sitting on the fovea. So we expect that when we start treatment, even the visual prognosis in this child, although it is a unilateral RB, will be better. But you know, a diffuse vitreous seed situation is sometimes slightly difficult to control.
We'll discuss that a little later, Dr.
Okay.
So how do you stage this now?
Well, so in International Classification of Retinoblastoma, this would be Group D. Yeah, and yeah, there is definitely no systemic metastasis. So it will be T2B N0 M0. He did not have any lymph nodes palpable. Yeah.
Now, if I, thank you, Feroz, for that. So I will come back to you again.
Okay.
Dr. Amita, ma'am, how do you treat? I mean, now we have got a Group D unilateral with the background which Dr. Feroz has mentioned already. How do you treat it, and reasons for that? You have to unmute yourself. Yes, ma'am.
Yeah, thank you. Yeah, so, and this is a very recurring question for us because most of our patients will present actually with Group D and Group E disease. So for us, there are two options, and this has to be discussed in, taking into account the family choices and primarily a discussion between the ocular oncologist and the family. So Group D, or at least a bad Group D and Group E disease, if we feel that there is going to be very less chances of ocular salvage, we may offer the patient enucleation upfront. But a significant proportion of our families would not be willing to accept that. So there are options such as, we've already discussed a little bit about chemo reduction already. So we may choose to give chemo reduction, see the response, monitor the response very closely, and in combination with either local therapies, and if the response is optimal, Group D and Group E, we may even consider taking them up for intraarterial chemotherapy if the family is very, very keen for ocular salvage. But all this would demand that patient is to be on regular follow-up and to comply with treatment. If we feel that that is not an option, so upfront enucleation is an option, chemo reduction either with systemic chemotherapy or where feasible intraarterial chemotherapy are other options. So a lot of discussion between the oncologist, the ocular oncologist, and the family to decide what would be the optimal plan for a given patient.
Yes, ma'am, that I think you have put it very nicely. I think Dr. Badera wants to make a point.
Yeah, I would like to share the same view, but so wherever possible for a unilateral Group D, sorry, if you can hear me, for a wherever possible for a unilateral Group D, I mean, you should take in for OAC because it's there should be useful vision in that case, and you are also salvaging the globe. So enucleation should be last on the list because if IAC is not possible, then it should be intravenous chemotherapy, and you can look at the response because even if there is no vision, you have the option of globe salvage, which is our second priority.
To give to this.
It's absolutely. It's just that we need to ensure that the patient would be able to come for regular follow-up and comply with that. So the chances of ocular salvage with systemic chemotherapy, extensive local therapy, or intraarterial therapy can approach 70 to 80%.
Yes, so that's correct. So if we enucleate, that may be probably the best option to offer for immediate cure. But then of course we are losing the vision and the eye in the bargain. If you offer chemo reduction followed by local therapies, there's the risk that if the follow-up is not adequate, and there's a risk that if it has metastasis, then of course it becomes a difficult situation to deal with. And intraarterial is an option, and centers who can deal with that is also an option. So I think Dr. Amita ma'am rightly put it. It's a discussion between the family, the oncologist, and the ophthalmologist to decide what treatment would be best in a particular child. Sorry?
Yeah, I would like to add there, because I think I again want to say intravitreal for a group D, if you give intravenous, there is around 40% cure rate. That is the response that you get. Then if the intravenous doesn't result in good response, you also have the option of intravitreal chemotherapy wherever it is done.
We're going to discuss that in a minute. We're going to discuss that in a minute. So we'll move ahead with the case, and Mohit is going to say the next. The family chose to continue with the eye salvage. Sorry.
Sir, just one note. When you're speaking, I'd request Dr. Mohan to keep himself on mute because the voice is echoing since you both are in the same room.
Yeah, correct. Sorry.
Okay. We discussed with they discussed with the family, and we started our chemo reduction for him. So he received the initially 6 cycles of standard dose VEC we had started, and he also received intravitreal topotecan for the vitreous seeds and 12 injections, and also intravitreal melphalan 4 injections. So his ophthalmological examination after completion of 6 cycles with local intravitreal therapy, it was suggestive of complete regression of the lesion. This was the UVA examination after post in December 2017, where he completed post 6 cycles of chemotherapy followed by the transpupillary thermotherapy. The regressed tumor with foveal spread and vitreous seeds regressed with residual calcified specks.
So,
how do you now? Feroz, coming to you back again now. How do you explain us this response? I am sorry, I don't think you have an option of pointer, but if we could just explain us, say we can see 4 prominent areas in this retinogram.
Yeah, so this was after the initial 6 cycles of chemo reduction and intravenous chemotherapy. You can see the tumor has very well regressed. It's more of calcification, a little bit of fish flesh in the margin superiorly, but it didn't seem active. Now, the good thing about this eye now, although it's a unilateral retinoblastoma, is like the nerve looks very healthy, and you actually have a very good clearing of the fovea. That means, so at this point of time, this eye is salvageable, and even the vision is salvaged over here with a good visual potential in this eye. Yeah. Superiorly also, one tumor was lasered actually.
Now, just I think Dr. Badra was making comment on that. That's intravitreal, and also other local chemotherapies which you give as part of your local therapy. So, what are the cases you decide on? Local in addition to giving local chemotherapy boost. So, which are the cases you think, and how you make the decision whether intravitreal or you want to give subconjunctival? And sorry, there's one more question actually to that also. We always worry that in intravitreal, when you give, there's a spread, concern of spread through the track. So how do you counter that, and how do you address that question?
Yeah, until 2012, we were all actually scared to go inside and poke an eye with intraocular tumor, because retinoblastoma, being a very cohesive tumor, it can actually come out of the needle and cause an extraocular extension. But then, different clinician scientists came up with a safety enhanced technique where we usually use a very small gauge needle, 30 to 32 gauge through the pars plana, in fact, so that, the intraocular extension is less. And then we also do cryotherapy at the site of the injection. And there are 2 drugs that we use for intravitreal chemotherapy now. Earlier, initially, it was melphalan. But gradually, like in my practice, I have shifted over to topotecan because it's less, toxic to the retina and the choroid. So if you're trying to salvage the eye, probably you would also want to salvage the eye with some, vision, significant vision. So I prefer topotecan in intravitreal chemotherapy. Now, when do I use intravitreal chemotherapy? In the presence of vitreous seeds, Now we are actually quite brave to go in with the safety enhanced technique. So any eye with vitreous seeds, we go inside for intravitreal chemotherapy. But if it's a very diffuse kind of a situation where you don't have a space to inject and there is a high risk of these seeds coming out through the injection site, initially we kind of reduce it with, of course, systemic chemotherapy or intraarterial chemotherapy, and even periocular chemotherapy of topotecan is an option. And once it is regressed and you get a space to go inside and control the intravitreal component, then we go ahead with intravitreal chemotherapy. So be it focal seeds or diffuse seeds, we actually resort to intravitreal chemotherapy as focal treatment for vitreous seeds. And we have extended the indication of intravitreal chemotherapy even for endophytic recurrences and even subretinal seeds. So yes.
So other modalities like subtenon and subconjunctival injections, are they still being used? And if so, when would you do those?
Yes, not too frequently as how we used to use earlier, but in a situation, as I told you earlier, if there is diffuse vitreous seeds where you actually don't have a space to go inside, then you give a periocular or the subtenons chemotherapy, reduce it to some extent where it's safer to go inside. That's when we use it now.
Thank you.
Yeah.
Now, in this case, Dr. Deepak Bansal, if you can hear me, I think we briefly mentioned, I think in a previous comment, but any other, I mean, would IAC would have been an option, intraarterial chemotherapy an option, and if you have some your own experiences at your center with IAC.
Right. So if you go by the literature for a group D disease, intraarterial is preferred over intravenous chemo. I mean, intraarterial has shown to have a better response over intravenous, particularly for higher stage disease. When I say higher stage, typically it means group D, specifically group D. The main concern is cost, because one cycle of intraarterial costs about 70, 80, 90,000, and typically 3 cycles are suggested. Whereas one cycle of intravenous would cost, depending on the setup, for us in a government setup, it would cost hardly 1,500 rupees. So there's a massive difference in the cost. So that's at the end of the day, that's it. That is what decides whether one would go for IAC versus IVC. But yes, if given a choice, one would prefer IAC. But then I know Chirag from Dr. Chirag from Intervention Radiology has also logged in. He's an interventional radiologist. And Dr. Usha Singh from our center, ophthalmologist, has also logged in. They often tell us that there are some concerns about complications of central artery ischemia. So I know that as per literature, with increasing experience, that tends to come down. But I think sometimes that is a concern, whether by doing intraarterial chemo, one may not end up losing some part of the vision as a complication. Although that may be more center specific and maybe that reduces with experience. So I don't know if you can allow Chirag to give any comments about intra.
Of course. If Dr. Chirag can hear us, you're probably most welcome to comment, sir.
Yeah. Hi. So we've been doing IAC for the last about 3 to 4 years, and it requires a very good, in fact, a longish kind of a learning curve because of the small babies, small arteries. And we had, I remember one case of retinal artery occlusion and ischemia. That was about 2.5, 3 years back. But now that we've been doing it, the ease and the comfort has actually kind of sunk in. So I think it's a good option. The only problem is the cost. It is, as Deepak said, it is close to about 1 lakh per session, which is kind of not very good for certain patients. But then yes, IAC is a very good option in expert hands. Yes.
Yeah. So I think a fair point. I think it's a center specific, and as you tend to do more and more, gain more and more experience, I think your results are definitely going to be better. Now, have you had any cutoff ages, like less than this age? Because what we see at our center, smaller babies, with obvious reasons, there are some challenges. Older children are slightly better. So we had some kind of experience at your center as well. I mean, what ages you probably feel that it is not a good idea to venture? Could you hear us, sir?
Hello, hello.
Hello, could you hear us?
Yeah, yeah.
Yeah.
So yeah, regarding the age actually is not a concern because we've done 2 months, 3 months. Initially, we used to prefer children above 1 year, but then with expertise, once you get a hang of entering the ophthalmic and reaching its ostium, age actually is not a concern. But then obviously, as I said, it requires
Yes.
a hands-on experience of at least 10 to 15 cases before you actually can tell the patient you can play a difference.
Great. Yeah. Thank you, sir. Thank you very much.
Can I comment?
Yeah, please.
All right. Yeah. So I agree with the fact that age really doesn't matter if the interventional neuroradiologist or a neurosurgeon is quite well experienced. So I had published our report, which is the youngest patient who received IAC, and it was 5 weeks.
Great. So individual experiences, center experiences, I think dictates this as an option.
Sunil, can I just add?
Yeah, please.
So, I mean, because we have a lot of fellows in this group, I think we must convey that for the large majority of patients, it's the intravenous chemo which will actually be given and not intraarterial. Maybe out of 100 cases, depending on the center, like for us, out of 100 cases of group D, I think only about 5 would end up getting intraarterial, and the rest 95 would get intravenous. It's
a fair point.
Retinoblastoma is considered to be more common in developing countries. So they are poor, and for some unknown reason, most of the retinoblastomas compared to the ALL patients tend to be poorer. So all the more reason that IAC somehow is less accessible to our patients as compared to intravenous.
Yeah, fair point.
Sunil, I'd just like to add one more point, that if we do have the privilege of offering IAC, for most Western data, they will choose to just go with single agent chemotherapy. But because we may be able to offer only limited cycles, most of our teams would actually prefer to go for double or triple, all 3 drugs, melphalan, topotecan, so that we can give them the best possible benefit within a limited
one
number
setting.
of cycles. In one setting, hopefully.
Yeah, that's true. Actually, we actually have shifted to a upfront triple drug regime just because of this reason. So we may not be able to call the patients again. So upfront, we are giving melphalan, topotecan, and carboplatin. So yes, we've shifted to a three drug regime.
Yeah, we also follow the same at TMH. We follow triple drug.
Right.
Now, Mohan, if you could carry with the case forward. Thank you for all your inputs.
Yeah. He completed treatment in December 2017. So he was on regular follow-up ophthalmical examination. So during ophthalmical examination, in the post 1 year of the completion of treatment in January 2019, so his examination was suggestive of recurrence of the disease in the right eye. This is the UEA picture, which is suggestive of recurrence in the temporal and some small nasal small tumors also.
So, Dr. Amita ma'am, I'm coming back to you now because we had, discussed this with the family, and we gave them options that time. Now, with this, new development, there's a recurrence now after we have treated him first time. What should we recommend to the family now?
Can we just see what the recurrence? Can you just show again what was the extent of the recurrence?
It was still a nasal temporal tumor and small nasal tumors. But if you see that, the nerve and all that vision potential is still quite good.
Yeah. So again, we'll have to sit down. This is multidisciplinary involvement. But as we should still be able to offer them some form of local therapy, or maybe perhaps in addition with some systemic therapy, in discussion with the ocular oncologist. And I think Dr. Furuz would be the best to recommend what would be the modality of therapy for the local control that we would opt for in this setting.
Yeah.
So the point which ma'am you're making is, I think for the fellows also here is, for the trainees is, I think retinoblastoma is, especially intraocular, is probably one of the unique diseases and when you compare with others, wherein even a recurrence, if there is a relapse basically, or a recurrence, it would be still dealt, with the merits of as if it is is it an upfront disease. So we still have a good scope of salvage. even in this condition. So yes, Dr. Feru, sorry I interrupted you.
Yeah, Sunil. Yeah, since I understand and believe it's more of the pediatric oncologist which is there in the gathering. Well, so one thing what I want to stress here is, yes, as you said rightly, that recurrences can happen. So the patient should not be let off after completion of systemic chemotherapy, whether the patient is primarily being seen by a pediatric oncologist or a medical oncologist. The patient have to have regular examination under anesthesia to look for recurrences, because the first 2 years after completion of systemic chemotherapy, be it or intraarterial chemotherapy, there is a chance of recurrence. So there need to be a very, very regular follow-up. In this particular case, so this is one of the picture. He had previously got nasal recurrences also. It was more of kind of, we were getting the feeling that it was a very resistant tumor. So all the nasal tumors, he has undergone a TTT, but at this point of time, he had this main tumor which recurred, vitreous seeds, and inferior to the main tumor, there is yet another tumor.
Yeah.
And yeah.
So,
after discussion with the ophthalmologist and family, he was started on again standard dose VC chemotherapy, and his ophthalmical examination was done before every chemotherapy cycle. It was showing of regression of other lesions except the persistence of temporal tumor was there. So he underwent plaque brachytherapy for temporal lesion in October 2019.
The family has been family, and I think the treating ophthalmologist, they were quite optimistic because there was a good vision potential still. Family was not very keen for enucleation, so that's how I think a second attempt to salvage the eye, and of course the vision was made. And although he had again good response except for that one lesion, and that's why the plaque brachytherapy was started. Now with regards to plaque, Dr. Deepak Bansal, do you have access to plaque brachy there? And if you could just help us, what are the patient groups you would try to use that as a local therapy for local control?
So we do not have access to plaque. It's available in Government Medical College 32. So I have kind of theoretical knowledge about plaque. So instead of giving external beam, one places a kind of a radio, the substance just along the orbit, so that a local radiotherapy is given, and there's less likelihood of adverse effects, but because the whole eyeball does not get irradiated, and chances of cataract, etc., may be less. So I'm assuming that any recurrent tumor not easily amenable to local intravitreal or periorbital chemo. So it's kind of an adjuvant therapy along with chemo, particularly in a recurrent setup. But I think I'll let the ophthalmologist answer this, because generally the shots for local therapy are
taken by the ophthalmologist. Yeah, so Feroz, there are some size criteria, how much thick it should be, how much wide it should be, where should be the location before we, give them the advantage of plaque, which Dr. Deepak already mentioned, the advantage of plaque being that it's not going to have systemic side effects, actual beam radiation. So how do you, what are those small nitty-gritties which you take in consideration when you offer plaque?
Yeah, the most important thing is it has to be a solitary tumor, Sunil. So you can't plan a plaque therapy if there is multiple recurrences. It has to be one solitary tumor, which is the only one active inside the eye. Because this plaque brachytherapy is a focal therapy again. Yeah. You're placing the plaque over the surface of that particular tumor, which will not act in the surrounding area. So the main indication is solitary tumor, whether it's a recurrence or even primary. Usually primary, we don't use it. The other thing is, yes, the size of the tumor depends upon what plaque, the size of the plaque that you have. So the plaques comes in 12 millimeter size, plaques comes in 16 millimeter size. So if an institute has all the sizes, then you can actually plan, the plaque for, even if you have a 16 millimeter plaque, you can give plaque brachytherapy to a tumor which is almost 12 millimeters in size. This is more applicable in melanoma. Now, thickness of the tumor, well, in retinoblastoma, since we don't use it for a primary procedure, most of the time it's recurrence, and the thickness is usually not much, it's not more than 5 or 6 millimeters. It's always less than 6 millimeters of thickness that we usually use plug brachytherapy. Yeah.
Thank you. So
this was the UVA picture after plaque brachytherapy, 1 month after plaque brachytherapy, which is in November 2019. This was the UVA picture with the regression of the tumor. And he continued with the standard dose. We continued after total 12 cycles of intravenous chemotherapy and intravitreal topotecan and melphalan and plaque brachytherapy. His UVA was done in December 2019. So it was suggestive of massive recurrence, and hence the enucleation with the PMMA implant was done in December. And the intraoperatively, there was a overt extraocular extension of the tumor medially was noted, and without involvement of the optic nerve, there was no optic nerve thickening. These are the pictures. This was the UVA examination after plaque brachytherapy in the December 5 weeks post plaque brachytherapy. And this was the intraoperative finding, where there is the massive extension through intraorbital extension without optic nerve thickening. And his MRI examination and bone marrow and CSF examination were done to rule out the systemic involvement. All were normal without involvement of any optic nerve. This is the MRI finding. And histopathology report, it was suggestive of a malignant round cell tumor, which is mainly involving the retina and choroid, extending to the sclera. And the meninges at the base of optic nerve were involved by tumor, but the resected end of the optic nerve was free of tumor. And the iris, ciliary body, and anterior chamber and optic nerve parenchyma was also free of tumor.
Dr. Amita ma'am, again back to you. So this is now a recurrence whereas an enucleation has been done, but unfortunately there is a orbital extension of the tumor. Fortunately, the nerve end is free of tumor. So what will the recommendation now to the family, ma'am?
Yeah, thank you. So the first thing is, with orbital extension, the child will need further local control as well in the form of external beam radiation. And we will need to take a call on whether, how long is it since the chemotherapy was finished?
1 month.
Ma'am, it has been a very fast progression. We finished in November, and December there's a recurrence. So November.
Yeah. November was the plaque brachytherapy.
Plaque brachytherapy, yeah.
They were supposed to come for EUA. They are very, they usually come on follow-up. They are absolutely high on coming for checkups and all. So 4 weeks they were supposed to have an EUA, but 1 week of delay. And this was seen in the nasal side, not the main tumor, which was in the temporal side, within 5 weeks.
This was anyway not covered with the, the plaque that was given.
Correct.
So the
Correct.
important is that the child needs to go for external beam RT, though we've, everything that has been done up to, so far is actually prevent the children from that. And that is what we would endeavor to do for most of our patients, is to, avoid external beam RT at this young age. But I don't think we have any option. And the need for further chemotherapy would again need to be discussed. But at the beyond orbital extension, I think there are no other features. There was no extension.
Not in the brain, not in the CSF, not in the marrow.
The most important thing is that the patient needs to proceed to external beam RT.
Okay, so what?
Can I, Dr. Sunil, can I speak?
Yes, ma'am. Yes, ma'am, please.
I want to make one point at this stage, that in a unilateral retinoblastoma, we try the eye salvage first time, and we get enough time to find out whether this is hereditary or non-hereditary. And our threshold in a non-hereditary retinoblastoma at the time of the first recurrence, or when you have demonstrated a persistent disease on the nasal side, indicating a little resistant tumor there with anticipation of problems in near future. If it is non-hereditary, I would have gone for enucleation at the time of the first recurrence and avoided radiotherapy, which in my opinion is more hazardous than putting a good, today you get such beautiful functional looking prosthesis that you can't make out. The child may not be able to see, but the amount, means the level of cosmesis that you achieve with a good prosthesis is so good that giving radiation and causing harm to the socket is much more harmful in my opinion.
Ma'am, we completely agree with you. I think that's what, when there was a first recurrence, there was a great interest as well as discussion with the family to go ahead with enucleation. But there are some of these families, especially if there's a vision is well preserved, there's sometimes such huge hesitation from the families to undergo that, and we had patients who, for the fear of enucleation, even were lost to follow up and never turned back to the hospitals again. So your point is absolutely valid. So when there was a first recurrence, there has to be a great case to be to be made for enucleation that time. And this is just that's why this case is being presented. Just shows that sometimes you may end up in a situation where you end up giving them more of.
There is one point in counseling which we must stress, that if this resistant looking nasal tumor progresses and becomes extraorbital, then you have a problem. Like you have just skipped, fortunately in this child, CNS extension.
Correct.
If there is a CNS extension, it is a 0% chance of life. Forget about the vision and anything else.
Correct. Correct.
You are doomed. So if you give this perspective in counseling to the parents, I'm sure every parent will choose a life versus the vision. A vision means eye. So life is the most important thing. So we have to drive that point home, that if it becomes little extraorbital and involving CNS, we have nothing more to offer. That is the thing.
Okay, so this patient, Mohan.
We discussed with the family and ophthalmologist, and we plan to give the systemic chemotherapy according to the extraocular retinoblastoma COG protocol, and followed by radiotherapy. So he received 4 cycles of extraocular retinoblastoma chemotherapy, and after that intensity modified radiotherapy of 45 grays in 25 fractions were given to the whole orbit. He completed his treatment in the May 8th.
Just basically a takeaway point is that what are the patients with with retinoblastoma? Although we make in every attempt that none of the patients should have the ER radiotherapy to be given to them. But all the patients you will recommend to have it, for the trainees who are listening. So who are the ones which will have to definitely go for external beam?
Is the question to me, Sunil?
Dr. Deepak Bansal.
Okay.
Yeah.
Okay.
Right. So all cases of orbital retinoblastoma need to receive external beam RT. So when I say orbital, it means extraocular, and
Correct.
it has to be as per the initial MRI or CT findings. And because sometimes when you get the initial MRI CT, there is orbital disease, but later on with chemo it disappears. So one has to remember that initially it was orbital. So the indication is to give EBRT, or if on your histopathology there is any evidence of extraocular spread. So all these patients have to receive external beam RT. One may not like it, but one has to give it if there is orbital disease.
And also probably stage 3 ones, where there is a lymph nodal involvement. And also probably if the nerve cut is involved, even though there's no orbital disease, but the nerve cut margin is positive.
So all that becomes orbital disease, either stage 2, and what am I saying? So extraocular spread, either microscopic or macroscopic.
Correct.
Anything which is outside the confines of the eyeball, either microscopic or macroscopic. And you mentioned about the preauricular lymph node. So sometimes one gets these cases of retinoblastoma whose preauricular lymph node is enlarged. So I think the literature on irradiating the preauricular lymph node is there, but no one really knows whether it helps or not. With chemo, the lymph node often disappears. So I'm not sure if there's a definite answer whether many people do include the lymph node within the radiotherapy field, but I'm not sure if it improves the outcome or not.
So I think stage threes, that is the ones who have got lymph node involvement. It's very important to demonstrate, because sometimes you can get inflammatory enlargement of lymph nodes also. So if they are diseased, if they are involved with it in the process, of course radiation is recommended and does help. Now Dr. Badra, I think you had raised a hand. Now, what are the? I'll come back to you. Long-term concerns with radiotherapy, and this is in the context of two major concerns. One is if you have irradiated an eye which is in situ, and you have done RT as a local control, but the eye is not been enucleated. Just sometimes it has been done in the past for local control, Dr. Feru. So what is the concern with the RT to the eye when the enucleation has not happened?
So you mean the stereotactic radiotherapy or the
Correct,
external beam radiotherapy?
Correct.
So we all know that there are associated side effects of external beam radiotherapy. More important in retinoblastoma is, if at all it's a germline mutation in retinoblastoma, they can have secondary cancers. That is which is more worrying in case of retinoblastoma and side effects of radiotherapy. Now, local side effects, our radiotherapist has already mentioned about it. Patient can have dryness, severe dryness affecting the cornea and the ocular surface. They can land up with cataract, which is like opacification of the lens and reduction in vision. And they can have radiation-related retinopathy. They can have radiation-related maculopathy, which affects the macula of the eye, further affecting the vision, and also radiation-related optic neuropathy. So the retinopathy usually is seen, 18 months to 2 years after the radiation. Sometimes you can see optic neuropathy, within 3 months after radiation, but these are the late complications. And I would like to stress, the more worrying thing is about being a germline mutation and secondary cancers. Yeah.
So Dr. Badra wanted to make a point, and we'll go to the second case. So are you there, Dr. Badra?
What I wanted to stress is that even we have discussed about the treatment part of it, but all retinoblastomas, irrespective of unilateral or bilateral, and especially this case, because this was unilateral multifocal tumors, it
can
should
be.
Yes, genetic, and should go for genetic counseling.
And, that's correct.
Yeah, coming to second case. Yeah, here is a 6-year-old female child. She was presented to us in August 2018 with a history of protrusion of the left eyeball, and initially she was evaluated at Yadgir. And initially she presented as a white eye reflex in left in 2017, but they didn't take any treatment. And the CT was done at Yadgir, where the left eyeball was enlarged with 3.6 into 3 into 3.1 centimeter and hyperdense with architectural distortion and large calcific foci. And the left optic nerve was appearing bulky and tortuous in entire length with intracranial extension, suggestive of query metastasis. And the features were in favor of left retinoblastoma with metastasis. She was referred here for further management, and the ophthalmical examination was suggestive of left eye retinoblastoma with the palpable left cervical lymph node. And there was left eye proptosis with left cervical lymphadenopathy, which was non-tender and hard in consistency. This is the MRI picture which was done in October 2018 with the involvement of the large bulky optic nerve and the optic chiasma also involvement of the up to intracanalicular and up to optic chiasma part also bulky. And it was suggestive of an ill-defined mass replacing the left gobe, and there is a lesion measuring approximately 4.2 into 2.8 into 3.3 centimeter. And also left optic nerve was bulky in its intraorbital, intracanalicular segment, and large round iso-intense lesion of the optic chiasma level, which was measuring into 2.5 to 2 centimeter. And there's also round to hole soft tissue lesion showing hypointense in T1 hypointense and T2 hyperintense noted in the left parotid and submandibular region, query lymphadenopathy. The feature was favor of ocular and optic nerve retinoblastomas. And CSF examination and bone marrow examination was done. It was normal. So the biopsy of left cervical lymph node was done, which was suggestive of a round blue cell tumor.
Ma'am, Dr. Amita, ma'am, I mean, we just heard the case and also the evaluation which was done. So how would you stage this patient, and of course, after staging, what would be your take on this patient? Do we still offer treatment, or send them home, and what are the treatment options you'll give them?
So definitely this is, the CSF in bone marrow is negative. And apart from the optic nerve reaching up till the optic chiasm, this is, we would classify as stage 3, because this is just local extension and we are not seeing a CNS metastasis. And CSF for malignant cells is negative, but with very advanced disease locally. So in terms of offering treatment, I think we would still offer treatment, and it would comprise, because we can at least, even if we are not able to one, there is still some chance that we may be able to cure this child with systemic chemotherapy, external beam radiotherapy. But also even if that was not going to be possible, systemic chemotherapy would still offer the child the best possible palliation, because this child would become very significantly symptomatic very soon if she is not already. So the starting treatment would be systemic chemotherapy. And she's a 6-year-old. We would I'd just like to make one point, because I saw in the chats a lot of things that the low dose and high dose chemotherapy in the context of I think I can just see Dr. Usha connecting that this is stage 4B, and yes, that that is correct. This would be stage ICRB group E. And this would be for extraocular RB, we would classify it as stage 4B, it's because of the CNS extension. And systemic chemotherapy would our first step forward. It's come up frequently in the questions on the chat. Yeah, whether this low dose and high dose chemotherapy, what does it mean in the context of retinoblastoma? So the high dose chemotherapy is still non-myeloablative chemotherapy. It's just higher doses of carboplatin and etoposide, and it is reserved for patients with extraocular retinoblastoma, and in the setting of adjuvant chemotherapy would be given for patients with extensive scleral invasion and for transected optic nerve margin positive. Now upfront surgery would be really, we will end up with, if it is a painful eye, we will end up with positive margins still. So we can consider that, but the transected margins will almost certainly be positive. So it would be preferable to give them high dose systemic chemotherapy upfront, assess for response, and then offer surgery followed by external beam radiation, because the patient already has extensive nodal disease as well. So upfront surgery would really not help us much.
I think I saw those chats also as well. I thought we'll address it a little later, but I think I think everyone is kind of probably we may have confused people, or I don't know. So I want to clarify, the chemotherapy which we have been talking about. So there are 3 chemotherapy schedules. One is VEC, which is the chemo reduction used in most of the intraocular tumors, VEC.
Yeah.
Then there's a chemotherapy schedule which is used for extraocular tumors, and there is something called as high dose chemotherapy with stem cell rescue. So these are three things which are talking about. Now VEC, which is used for intraocular tumors, can be standard dose, which is the most prevalent dosing which is used, and it can be high dose VEC also. The difference is that the carboplatin dose and etoposide dose is a little higher. Now, as a different subject altogether, where do we employ standard dose VEC and where do we apply high dose VEC in an intraocular setting? That is one. The second is the extraocular chemotherapy, and if you will show this case, what we have used on this, or the previous case also, the previous case, as I showed you that, COG protocol, which is based on higher doses of etoposide, carboplatin, and cisplatin also is used in that protocol, which is higher dose and used for extraocular, and different groups have used different treatment regimens and for extraocular retinoblastomas for chemotherapy point of view. The third component is high dose chemotherapy stem cell rescue, which is either etoposide carboplatin cyclophosphamide or etoposide carboplatin and thiotepa. These are used as autologous transplant. These are really autologous transplant, and that's what I showed in my chemotherapy presentation also. These are the ones which can be used for stage 4, predominantly have been tried in stage 4 retinoblastoma. So this is, I think the context is this. So when we're talking of high dose VEC, that means VEC in intraocular disease. When we're talking of high dose chemotherapy autologous rescue, stem cell rescue, that will be like an autologous transplant. And in between is again high dose chemotherapy, but it is in extraocular disease setting, which is based on 4 or 5 chemotherapy drugs which are used in that setting. Now, Mohan, I think we're going to tell what happened to this patient and we can discuss further.
We discussed with the parents, and also here discussion, there are a lot of social issues. They didn't want to stay in the hospital although, so we couldn't start the extraocular protocol. So we started on high dose VEC chemotherapy from the after diagnosis. So after 2 cycles of chemotherapy, her proptosis had reduced. So we gave total 9 cycles of chemotherapy until the July 2019. So after that, enucleation of the left eye was done in August 2019. So histopathology, which was suggestive eyeball filled with a fibrotic calcified lesion with the dense histiocyte infiltrate, and no viable tumors were seen, and optic nerve resection margin was free.
Is that I just put a little question here, signals of negative margins here. Dr. Deepak Bansal, would you want to comment on that, because it comes sometimes, in some of the discussions. So although there was no involvement going into the chiasm, chemotherapy, the tumor has been removed.
Yes,
now nerves,
as I said earlier, sure. So because the CT or the MRI was already showing that the tumor is going up till the optic chiasma, the histopath practically has no meaning here. Even if it is negative, it just shows that the chemo has taken care of it. One will have to give EBRT going up to the optic chiasma as well as including the lymph node which was involved in the beginning.
Correct. So I think this was important point, and in the previous presentation also, when I said high risk features, these are high risk features only when you do upfront enucleation. If you are not doing upfront enucleation, you're giving chemo reduction first, those high risk features do not have significance. I think Dr. Pooja has raised hands. She wants to ask something.
I wanted to ask a question. Yes, sir. Can you hear me, sir?
Yeah.
Yeah. So my question was regarding the number of cycles of chemotherapy that is recommended in extraocular retinoblastoma. So is there like a minimum or a maximum number of cycles that has to be given in these children? And is there a factor which will help us decide how many we need to give in these children?
So Dr. Amita ma'am, you want to take that question?
So for extraocular, most patients will end up getting 12. But in general, the question that you asked for minimum, for extraocular, they may end up getting 12 up till 12 cycles. Beyond that, there is not much advantage, but the minimum would be 6 cycles.
Yes, ma'am.
So Dr. Pooja, it's also again in the context of what chemotherapy you have given. So that's what I was, previously when I was trying to explain different types of chemotherapies. The one, for example, with the COG is being giving is a pretty heavy duty chemotherapy. These are quite myelosuppressive chemotherapies based on carboplatin, cisplatin, etoposide, and those are given every 21-day intervals, and so you give 4 to 6 cycles of those, and not more than that. It's a pretty intense. But for example, in this patient, we have used this VC, high dose of VC, and as ma'am said, 6 to 12 cycles, anywhere between 6 to 12 cycles, because you have to reach a stage where you can safely enucleate the eye, and you have achieved a good local control, and then good systemic control, and then you going to employ your local therapies, whether in enucleation with external radiation. So it depends on the context of what you're using. If you're using the real extraocular high dose, high duty chemotherapy, like the COG uses, 4 to 6 cycles is what they recommend.
Thanks, sir.
Yeah. Sunil, can I just?
Yes, Dr. Deepak. Yeah.
So, for any new entrant to the retinoblastoma field, I totally understand it is extremely confusing, the type of chemo and the number of cycles. I remember suggesting to Dr. Honavar once that the so-called terminology high dose chemo should not be used because whenever the ophthalmologists say high dose, for us it means high dose with stem cell rescue. But unfortunately, retinoblastoma now it's kind of got fixed, wherein the VEC high dose simply means that a little bit higher doses of carboplatin and little higher doses of etoposide. It does not mean stem cell rescue. So the chemo for extraocular retinoblastoma, if you check the UK protocol, it is actually standard dose VEC 12 cycles. Whereas Dr. Honavar's group has shown that a bit of higher dose of VEC is actually better than the so-called standard dose of VEC. And as Sunil said, the COG follows a totally different protocol. They give cisplatin and cyclophosphamide along with vincristine and etoposide only 4 cycles for extraocular. I think in developing countries, one would not like to use that protocol in public hospitals because then the myelosuppression would be very severe. So I think we are, there has been no head-to-head comparison of high-dose VEC with the standard dose VEC, but Dr. Honavar's group has shown that with historical control, their outcome is better with the high-dose VEC as compared to the standard dose VEC. So I guess the answer is 12 cycles of higher-dose VEC is what many centers in India would use, but some are using the standard dose as well.
Dr. Sunil, I have a question.
Yeah.
This is Sujata. Hi. If there was an extension right up to the optic chiasm, does the neurosurgeon get involved in such a surgery in addition to the ophthalmologist?
Okay, so I can ask Dr. Feroz to take it, but I cannot. Dr. Feroz, you want to take it?
Get involved. So whatever like Dr. Has mentioned, the initial staging, whatever you have is the stage for the treatment. But obviously when you give systemic chemotherapy, high dose, not the autologous stem cell rescue high dose, what we do is we do radiological assessment after 3 cycles of high dose chemotherapy, and then look for radiological regression of the tumor, be it the optic nerve extension or the orbital extension. And if at all it is not regressed after 3 cycles, we again give 3 more cycles for maximum radiological regression, because that's the evidence for us to enucleate. So once that it regresses, most of the time it regresses, then we go for enucleation, which does not involve a neurosurgical approach. And
So-
I would like to comment on the study that we conducted. Dr. Honavar, I am part of the team. So the orbital retinoblastoma, the protocol that we follow is the high dose, not the autologous stem cell rescue one. We give 12 cycles, and we had looked into 30 cases of primary orbital retinoblastoma without systemic or regional lymph node metastasis at presentation, and the survival was 90%.
I don't know.
Shall we conclude and then the case first, and then I think we can probably address.
Yeah.
Yeah, her PET CT also was done in October. The post-surgical changes of left enucleation was there with a prosthetic eyeball, and there was no moss lesion or abnormal uptake is seen in the left orbit, and there was no abnormal hypermetabolic lesion elsewhere in the body. And we gave total 12 cycles of high dose VEC chemotherapy, and she also received the external beam radiotherapy to the orbit and to the left cervical lymph node site. So currently she is a follow.
So
would the radiation, does it involve the again the extraocular part back to the optic chiasm or no?
Correct. So it includes the apex of the orbit, and
including the chiasm.
Chiasm, yes. And
Okay.
and how do we now, Dr. Deepak, how do we prognosticate the family? There has been a good response to chemotherapy. You couldn't see even a single viable cell after chemotherapy 9 cycles, and so the radiation has been given now. So how do we now prognosticate the family?
I mean, all that I can say is it's not good. I mean, we were even talking about not giving therapy upfront and doing palliation. So, whenever I see these cases wherein the tumor has gone up to the optic chiasma, I always wonder whether it is a CNS Mets or whether you would call it a local disease. Because if you call it CNS Mets, then you're actually not going to treat. So I heard Dr. Amita's comment that it's kind of traveled along the optic nerve and reached till the optic chiasma. So I would like to know if anybody in the group has any experience of treating such cases, and has there been a survival? Because this comment that it's local spread and not CNS Mets does make a lot of sense. but I'm not sure world over what is the outcome of these tumors which go up till the optic chiasma and are treated with chemo and external chemo RT. So the prognosis is very, is poor. I don't know whether I can give a number to it or not.
If I may put in a word.
Badra, yeah.
So what Madam said, so this extension into the pre-chiasma, actually as per the classification staging, it comes into CNS 4B. So this is not as bad as those who will be CSF positive, CSF cytology positive, but these are prognostically bad. And in the COG trial also, the CSF positive, none of them actually survived. And even for those who had up to the chiasma, their prognosis were very bad, 15 to 20%. But this chap was actually fortunate enough to have a CR and a regression from the chiasmatic size after chemotherapy. Usually it doesn't happen. Even in our patients who have chiasmatic involvement, the regression with chemotherapy is not that good. It doesn't come from the chiasma, but this was very good. But even then the prognosis, I don't think more than 20-30%.
Yeah, Badra, I'll accept. I agree to what you said. So I think it should be in the range of 10-15% at the most. I showed you some data on 4A, 4B, and 4C, where there's a meningeal enhancement, that none of the meningeal guys in CSF spread guys would survive. It's 1 or 2 occasional survivors. But these ones, as Dr. Mehta, said, is a local extension. So there is a 10-15 at the most chance that, they may have a long-term survival. So I think with that, we probably conclude our case, what we had to find. And if any comments there, and then we can take questions. I think there are some questions on the chat box. I can take those.
Dr. Sunil, I still wanted to understand from you your take on the neurosurgical.
Okay, so Sujata, so the thing is this: so you want a neurosurgical involvement if there is a complete excision which is being planned or is required. So it probably I think it was coming from other tumors in that area, for example, head and neck, and it's going into anterior cranial fossa, and then you need them to help excise. But here, the point I think which everyone is trying to make is that the excision of this tumor, because it's become it is extraocular, gone to the CNS. Excision by itself is not going to be of any significance, because you'll never get a good excision with a negative margin. This is going quite deep into the chiasm, and even if they operate it, then once the child is going to be blind, number one, and number two, you may not get a good negative margin anyways. So what are we trying to achieve by doing that? The only thing which is basically for a local control is to help, as Dr. Feroz made a point, is that 3 cycles they evaluate after with MRI whether if the chemo reduction has done a good local control and the tumor has shrunk, and you get on imaging a good idea that now I can go in and take out as much as we can and then consolidate with radiation. So having a neurosurgeon involved, I don't think they'll be able to operate in this area and get a negative marginus, and the morbidity is going to be quite huge.
Okay, and I guess the radiation will act as local therapy.
Local therapy, yes.
Yeah. Thank you.
So I think there was a question on the chat box I saw. Why not exentration? Feroz, I know that we have gone away from exentration in orbital tumors, and but still, if you want to make a comment on exentration as a not enucleation as a local control measure.
So we had gone away from exentration at this point of time because of the multimodal treatment protocol that we follow. So basically, in an orbital retinoblastoma, the principle is, it's multimodal because you want to reduce the size of the tumor as well as also take care of the systemic metastasis, which is taken care by the systemic intravenous chemotherapy. And then you're not sure that whether there can be microscopic residual, which is surgically, of course, not cleared with enucleation. So that's why you again beat it down with radiotherapy. So overall, you're taking care of the systemic part as well as the local area with radiotherapy and trying to conserve the orbital tissue. So radiotherapy, in fact, takes care of any residual microscopic tumor in the orbit in case of orbital retinoblastoma. So with this multimodal treatment protocol that we follow currently, we have walked away with exentration.
I would just make it, like to simplify to the residents what we do actually in an orbital retinoblastoma is, as everybody has correctly put it, we give chemotherapy and then we reassess after the neoadjuvant chemotherapy. And if there is no overt orbital disease, that would be enucleation. And if you have overt orbital disease, then you might try in for excenteration. And anyway, there would be RT following that and chemo following that.
Thank you, Badira. And any other questions from anyone?
So Sunil, there was in the chat I saw, I hope people are not confused between intraarterial chemotherapy and intravitreal chemotherapy. It's not used for the same purpose. So the primary management of retinoblastoma involves systemic intravenous chemotherapy or intraarterial chemotherapy or enucleation. So these are the three primary mode of management in retinoblastoma. Intravitreal chemotherapy is not used as a primary management. It is
It's an add-on to your systemic treatment.
Add-on or adjuvant treatment where you're trying to control the local disease, as in the case of vitreous seeds, as in the case of the subretinal seeds. So it is not primary management.
Yeah, so thank you for clarifying that. Any other questions we have from anyone?
So I would like to ask Badira if in Tata they are using the VEC standard dose or higher dose for orbital disease, and also from if there is anybody from AIMS Delhi, what kind of dose are they giving for VEC for orbital disease?
So we are using the standard dose of VC. We are using 12 cycles. After 4 cycles, we'll reassess. If there is overt orbital disease, excenteration. If no overt orbital disease, enucleation, RT, and complete the 12 cycles. That's what it is.
Yeah, so I think this
so
is
Dr.
a very good
Deepak,
topic,
we have been using for our orbital disease. So we have been using the COG. Most the one case we presented wasn't that. It was a high dose VC. But we have been using the extraocular COG protocol, which is the 4 condensed cycles. I mean, it's probably a very subjective statement, but I personally feel that the response to those is quicker and faster. And myelosuppression is going to be there, but it's not going to be hugely different than what we use for other diseases like immune sarcomas and tumors like that. So it is manageable, and it's a shorter treatment. Of course, 12 cycles means 1 year of treatment of VC, and then radiation and other things. So it's a more condensed form. You finish quickly, and toxicities are manageable. It's not hugely different from what we do in other malignancies.
Deepak, just to add, the conventional high-dose chemotherapy, there isn't so much, more myelosuppression. In fact, they seem to tolerate it almost as well as their, the standard dose or high dose in this context. Though all of us were a little perturbed because some of these children are very small, they are very malnourished also, especially, and then I've also been concerned since we started work on this. But there doesn't seem to be much much more myelotoxicity than you see. And the other thing is that lots of centers choose to give it every 4 weeks when they're giving high dose rather than every 3 weeks. And I don't know whether that also contributes to, so there is again a little discrepancy at the, frequency of cycles. So there is, and whether when most of them are using high dose, they tend to use a longer interval, whether that also, the cumulative myelosuppression is more recovery before the next cycle. So, and those who use it for orbital extensively, like Dr. Hanavar, they definitely feel that there is much to be gained by choosing the higher dose. Like you said in literature, if we review, it's all over the place, the doses.
Yeah. Any other questions? I think there's something which been posted. So there's a question that is there a limit to the number of chemo cycles? I think we went up to 12. So is there a limit more than 12? What do you say on that?
So I think that it's the pros and cons of continuing with chemo. As Dr. Purna Kurkure has said, sometimes there is a bit of a war between the pediatric oncologist and the ophthalmologist, because one has to remember the basic rules of number 1 is life and number 2 is vision. So sometimes there's a tug of war with this, whether the vision takes over the life. So when it was said, Sunil, you had mentioned that the family did not agree for enucleation. That's we see it every day. But sometimes, when the message is similar, both from the oncologist side as well as the ophthalmologist side, then it is easier to convince the family. I have burned my fingers many times by counseling for enucleations and the patients going absconding on treatment. So I totally agree that the moment you mention enucleation, the family might say yes upfront in the OPD, but then they'll go home and the in-laws and the parents will tell them not to go to the hospital again. So anyway, I'm straying away from the question, the number of cycles. So it's actually depending on the doses. So with VEC, I don't know, for some reason that it's stuck at 12 cycles for some unknown reason. I don't know what is the science behind it. And you had mentioned about COG. So they give 4 cycles of chemo for extraocular. I agree with your comments that it might be better, which we don't know. The problem is that these patients are very poor. And if we end up losing even 1 or 2 children to febrile neutropenia, then the whole purpose is lost. So I think in lower middle income countries, wherein the patients with extraocular disease tend to be even more poorer, one has to be careful with using the COG protocol. I do agree that the VEC higher dose would definitely be manageable because that involves just a little bit higher dose of carboplatin.
So yeah, so I think there's also on the number of doses which was mentioned. I think it's also indirectly telling you have given 12 cycles already. This seems to be a chemo-resistant disease, so it's not going to achieve any more tumor control by adding more and more cycles. And also there's a concern of the number, the amount of etoposide you're going to give to this child. There's already a high risk of second malignancy, and the cumulative exposure to etoposide may also be a factor in the long term. So that's how I think it's kind of, if you're not responding in 12 cycles, you're probably not responding. So there's no point in making a dead horse run. Any other? Sorry.
So Sunil, regarding the point of etoposide, so I used to think the same thing. So I remember in a meeting, Dr. Honawar mentioned that apparently etoposide in retinoblastoma has not shown to increase the incidence of second malignancy. Yeah, so although it's very tempting to think like that, but apparently this etoposide thing doesn't work for retinoblastoma, something like that. I'm not too sure about it.
No, but I don't think Dr. Deepak, we have enough data to the amount of etoposide which has been used in the number of cycles. So that's what if we use more cycles and the more doses, like in high dose etoposide, the comment may not hold then. So if there is a high dose VCs, etoposide is higher dose, not only carboplatin, etoposide also higher dose, and then you are extending to more than 12 cycles. So that we don't have that data probably to suggest either ways.
Yeah, because cumulative etoposide would come to around 2 to 3 grams per meter squared, which is the threshold for your
threshold. Correct.
Yeah, it's well within that.
So Vibha, please go on.
Yeah, I just wanted to make a point that with this 12 cycles of etoposide, I have seen one child, she came with secondary ML and we lost her. She received 12, even a little bit more than that. And so I always worry about the cumulative dose of etoposide and the secondary effects. That's the point I wanted to make. Yeah. So we lost one child to secondary AML.
Yeah, so fair points. I think we probably don't know yet. So what is the threshold? So I think if there are no more questions, we're also I think past time. I thank you all for your participation and enthusiasm for this inaugural teaching program. So I think we had a good, healthy discussion. But I think more than that,
congratulations to you, Sunil. It was very well conducted, and I think this was a very good session. I'm sure everybody.
No, I think the participation and your contribution. So experts have been really great. So I think your experiences and your your comments have really made the difference. And I just want everyone. I think a lot of people have logged off, but then I want you all to participate, continue participation, and volunteer to present these topics and cases. And I think the scientific committee who's been created, they will be coordinating with you. So we'll have these sessions every week till we can, and if it's becoming too much, we can reduce the frequency, timings can be modified. So give your feedback and comments, we can work on those and modify as we go along. So thank you very much, and special thanks to the 3 experts, Dr. Amita ma'am, Dr. Deepak, and Dr. Feroz. Feroz especially because she's a guest for us in the Pediatric Hematology Committee and and has agreed to spend this evening with us. So thank you very much, and have a lovely evening. Stay safe.
Thank you, Sunil.
Thanks.
It has been a pleasure being here. Thank you so much. Thanks to everyone.
Thank you, Pranchal. So I thank you for being there to hold this meeting and help us solve this way. Yeah.
Thank you, sir. So I request everyone to kindly fill the feedback form. I've sent the link on chat, and we'll circulate the link on
in the
WhatsApp.
email also. Yeah.
Yes,
yeah.
We'll email as well. Thank you, everyone.